Hi Francine, it is me, Deanna Trainor, and me, Michelle Rathbun, and we're doing a collab video of us reading our medical terminology, pronunciations, worksheets. So Michelle's going to start us off. Alright, we'll start you off with thoracic myelopathy complicating acute meningococcal meningitis MRI findings. Alright. Spinal cord dysfunction is a rare complication of meningococcal meningitis. We report a 17-year-old patient who had a 3-day history of fever, headache and vomiting, agitation, and unresponsiveness. Cerebrospinal fluid showed a marked white blood cell increase. The patient was given intravenous medication. Over the next 4 days, he developed weakness of the lower extremities with areflexia and extensor plantar responses. MRI revealed contiguous hyperintensities on T2 weighted images involving the thoracic spinal cord from T4 to T9 and 4 brain abscesses. 5 months later, he recovered brain function, but the paraparesis remained. This case illustrates that myelopathy may complicate acute meningococcal meningitis, possibly due to a vasculitis, stroke, autoimmune myelopathy, or direct infection of the spinal cord. Awesome. Great job. Thank you. Alright, I'll read the next one. A case of motor neuron disease and dementia and apraxia of the upper limb. We report a 61-year-old right-handed woman with motor neuron disease, dementia, and apraxia of the upper limb. The patient developed clumsiness of the right hand and dysarthria 2.5 years prior to admission. Neurological examination showed limb kinetic apraxia and ideomotor apraxia, predominantly on the right side, in addition to dementia and arthria. There was a mild muscle wasting in the neck. A muscle biopsy from the bicep muscle of the arm, as well as a needle EMG, revealed neurogenic changes compatible with motor neuron disease. Brain MRIs indicated pyramidal tract degeneration. 3-dimension brain perfusion imaging generated from SPECT SPECT demonstrated an asymmetric decrease in cerebral blood flow in the frontotemporal regions, predominantly on the left side. This case suggests that asymmetric limb apraxia can be associated with motor neuron disease. Yep, that's how you do it. Alright. Sagittal spinopelvic alignment and body mass index in patients with degenerative spondylolisthesis. The sagittal orientation and osteoarthritis of facet joints, paravertebral muscular dystrophy, and loss of ligament strength represent mechanical factors leading to degenerative spondylolisthesis. The importance of sagittal spinopelvic imbalance has been described for the developmental spondylolisthesis with isthmic lysis. However, it remains unclear if these mechanisms play a role in the pathogenesis of degenerative spondylolisthesis. A group of 49 patients with L4 through L5 degenerative spondylolisthesis was compared to a reference group of 77 patients with low back pain without spondylolisthesis. The following parameters were measured on lateral lumbar radiographs in standing position: L1 through S1 lordosis, segmental lordosis from L1 through L2 to L5 through S1, pelvic tilt, pelvic incidence, and sacral slope. Awesome. Okay. A case of mucopolysaccharidosis with lower leg paresis due to thoracolumbar kyphoscoliosis. We treated a patient with type 4 mucopolysaccharidosis, Morquio's disease, with lower leg paresis due to kyphoscoliosis. A 65-year-old woman presented with Morquio's disease. A lateral radiograph demonstrated the classic bullet-shaped vertebrae and a 65-degree thoracolumbar kyphosis. After the age of 60, she suffered from numbness in both lower legs and walking disturbance. Bilateral patellar tendon reflexes were exaggerated. MRI showed compression of the spinal cord around T12 to L2, with a highlighted area of change inside the spinal cord. Myelography and computed tomography after the myelography showed narrowing of the subarachnoidal space and deformation of the spinal cord around the T12 to L2 level. Thank you very much. Hope you like our collab. Like, comment, subscribe, leave a video response.